we've got an hour, which is a little bit short, and people will still be wandering in, but we'll crack on. So my name's Jeremy Nichols. I'm the Chief Executive of Social Value UK, which is a membership organisation, part of an international community of people who want to change the way the world accounts for value, because we think the current way is a bit shot. We're not allocating resources effectively, and at that big level, that's increasing inequality, and we really need to sort this, and part of it is what I'm afraid is often put under the word measurement, although to be honest, I'm not a great fan of that. And so this title is perhaps a little bit of a misnomer, Measurement Masterclass. You can't do a masterclass in an hour, I suspect. And we're going to be talking about some of the wider issues than just the bit about how you measure things. We're much more interested, I would say, in what you decide to measure in the first place than how you subsequently worry about measuring it. We've got members throughout the world, but concentrated in the UK, and the biggest concentration of our membership is in Salford. And so we are ably supported, I hope today, by two people, both from Salford. So, Anne?
So hi, I'm Anne Lithgow. I work for Salford City Council. I'm a strategic manager there in the sort of policy and public health area. I'm also on the advisory council for Social Value UK and the director of the Social Audit Network.
And Chris.
And I'm Chris Dabbs. I'm from a social enterprise called Unlimited Potential. Our core business, we do what I call social innovation for happiness. And for my sins, I also chair the Social Enterprise Council at Greater Manchester Chamber of Commerce.
Thank you. So how many of you are already measuring stuff? Most. Job done, really. Oh, yeah. I think the number one thing is, that's great, do a little bit more. Right, so alternatively, this is the view you often see about this. I can't remember, unfortunately, who it was that said this. Anybody agree with that, though? Kind of sense? Then we've got the measure, you can make it up. You just put it in a glossy report, smiling children. That's good. So I think we do see that quite a lot as a view. But I think the truth is, it's not the case, actually. I mean, you can do this in a way which is useful. And we're going to keep banging on a bit about stopping worrying so much about technique and thinking as much about culture in organisations and making it useful to what you do. There are two main ways we see of thinking about putting social value into the commissioning, the Social Value Act bit of this conversation, if you want. One is, let's add something in. People talk about the additional values. We'll have a bit more, please. We're going to buy that from you. We want a bit more. And that's okay. And then the other way is embedding it in the heart of that contract, which we're much more interested in. Because if you look at the additional one, here's an example from a local authority policy, where they say, that's what we mean by additional. So honestly, it's done, because all you need to do, if you are tendering into that, is to tick as many of those as you possibly can, and then you will be adding social value. Personally, I have not only a worry about the pre-described list approach of that and the weighting within it, but I would also have a worry that some of these things are being seen as social value as opposed to others that are not. It seems quite a weird list, but more importantly, it ends up in contracts that look a little bit like this, where the social value is 2.5%. And so you have to really think carefully about how much time and energy you're going to be putting into measuring all those things if it's only ever going to be 2.5% of the contract in the first place. So additional social value, that's about as much as we're going to say about it. We might come back to it, because the bit we're really interested in is embedding it. And we're going to do that with you in an exercise, we hope, with a little bit of interaction consequently. And we're going to do it with a case study. We'll see how we go in the time, around providing advice and support to people at risk of excessive drinking, or people with a drink problem. So, here we have the commissioner operating on behalf of the purchasing of this particular service. Here we have the manager, the social entrepreneur who's running this service, and here we have you lot, the people at risk of excessive drinking. Okay? So you're going to act for us today wearing that hat. Now, obviously, a lot of the time in this process, the people whose lives are actually being affected do not have quite this level of involvement. The conversations are happening over here, but today we've got you all in the room to help. And we're just going to go through the kind of issues that emerge when you're thinking about value in this, the measurement bits, and we'll see what comes out. basically. So there are lots of stakeholders in this, but we're only going to be worrying about one today. Obviously, we would want to worry about the others as well. We need to think about them. But today we're going to zip through with just this bunch. So, anybody, what is the output of this service?
Advice and information.
Sorry?
Advice and information.
Advice and information? Anybody else?
Decreasing the amount of young people, whatever age.
Decreasing the amount of young people. We've moved on to young people now.
Yeah, sorry.
That's fine.
Trust,
Yeah,
sorry.
Aspirational. Yeah, yeah.
Numbers of people screened to see how risky they're drinking.
Number of people screened. Okay.
Just hospital admission.
Okay. So already, first bit, we've got a range of potential ways of thinking about what even we mean by an output. So, Anne, commissioning perspective for this service, what would you think of as an output?
Yeah, we'd be in sort of numbers of people going through the service. We'd be in some sort of basically measurable numbers type things.
Yeah.
We might start to think about some qualitative things, but we'd probably not be
Not that
sure.
much at the moment.
No.
Numbers of people, Chris, anything outputs for that?
Numbers of people we've given advice and support to.
Yeah. So that's it really. You've had some money and you've spent it doing something. And that is what an output is. I think generally, I mean, you'll get variations around that, and people who, I see people describing that as an outcome quite a lot, and that of course doesn't help any of us because we all then get immediately confused. But really, you've had some money and you've spent it doing something. And in this case, what we have done is we provided some advice to some people in a number of sessions. I think we haven't even got that. We haven't got the people. Even worse measure of output there. Simply, we had some sessions. We didn't know if anybody came, and you will still find people willing to pay for that. Well, you put the sessions on, but did anybody come? But that doesn't really matter either, does it, surely? What, then, is the outcome, do you think, everybody?
Number of people who've stopped drinking or cut down.
Number of people who've stopped drinking or cut down drinking? Anybody else?
But you don't see them again in some ways.
You don't see them, yeah, just get out. Never come back. Yeah.
Repeats, is it doing, not seeing them?
I mean, I think that's fair enough. What do you think at this level?
At this level, yeah. I mean, we'd probably just see, how many people are not now at risk of excessive drinking.
Yeah.
Yeah, if I could get away with it, yeah.
If you could get away with it. So there you go. Some people drink less or are therefore less at risk, but the less at risk still worries me, and I think Chris's point, get away with it. It's true because we still don't know whether, if you measure that, there are people actually are drinking less.
Reduce the impact on the community.
Right, so hold on a sec, yeah, because you're right, I think. I think we're all going, that is an outcome. Something has changed is how we think about that. Those people's lives have changed. They are now drinking less. But would you be happy commissioning on
Not itself.
that? No. What's wrong with that?
Well, so what? What's that? Has that actually made any difference? Is it
Okay.
worth the investment?
We'll explore that, yeah?
I would like to know from the Commissioner why these people are drinking in the first place.
Okay, so certainly we're going to have some information about this group. We've jumped in with a kind of, let's over-generalise at the moment, a group of people who are at risk without any of the kind of understanding about what were those causes. Because clearly the different causes of that will have different relationships to how effective a particular activity is. And some activities may be more or less
So
effective.
what I'd like to ask the Commissioner, if you don't think that's enough, how are you working with public health to provide that evidence that works?
Okay, so hold that thought, okay, just because we're gonna, it will come, yeah? Oh, just before we do that, Chris, you're not managing this service. Are you happy about measuring that? Does that feel good enough for you?
If I'm trying to please the Commissioner, yes. In terms of the social impact we'd be after, are we addressing the root causes of the excessive drinking, which will be nothing to do with alcohol.
Right.
It will be loneliness and isolation and those sorts of things.
So to your point, what were the causes of that? So who should you be worrying about, if not the Commissioner?
Well, our starting point would be the people themselves.
Can I make
Here
a
they
point
are,
on behalf of the Commissioner? Part of the teams have things like joint strategic needs assessments. They do collect lots of data, and they do lots of research, things like that, and they then commission a service. So actually what we're probably talking about here is the bit where they think that they, and I did my words carefully, they think they've done all the work and they know what the problem is, so they're going to go and buy it. But is that commissioning?
Right. Okay, wider thing, but yes, I don't disagree. So, a couple more thoughts?
How do we know that the outcome was the result of that service? Suppose the person met an inspirational person somewhere
Okay,
else.
keep that thought, come back to that one as well. Yeah.
We need to know the impact of what they do differently as a result of the outcome.
So that's the bit I want to do for now. The bit that this, for all of us said, well, so what? I mean, that's the phrase. And we use that phrase quite a lot when thinking about this. There's something nagging in here. However, what would you say? You are people who are drinking too much. We'll move on from that. And now you're drinking less. Is that what you wanted? Or is there something else that you wanted to happen in your lives? Imagine you're wearing that hat. Lewis. Just thinking about, what do you want to happen now that you're drinking less? Was that all you wanted from this service? Or was there something else you were...
I would want that what caused me to drink
Had gone
improved.
away.
Yeah.
So Chris is...
I would want improved health, whether that's through eating or exercise or giving up smoking. I would want to improve my well-being as well as
Yeah.
reducing the amount of
I like that answer because we want to go a little bit further. Now, obviously, the healthier bit isn't the only change that happens. What other kinds of changes can you think that might happen? Yeah?
more functional.
Well, functional.
Or
Happier, quite big. Okay. Anybody else?
I want my mates to be asking me out again.
Mates to be asking you out again?
I'm
Because
not drunk all the time.
yeah.
More tax to the local community.
Is that what you want?
Yeah, I want to.
You want to be paying more
Reduce
taxes?
the social bill and increase the income.
As you're a person who's drinking too much, and you personally are saying, that's okay, very good. Take notes. Yes.
I want my housing situation sorted out. And
Right.
my debt sorted
So that
out.
as a result of drinking less, you're now able, functioning, to deal with some other issue, which was your housing situation.
I want to get a job.
Joel.
Want to get a job? I would do. I've got to keep it, get a job. Anybody else?
I want someone to visit me because I'm lonely.
Right. So, yes.
I think you've made an assumption that I don't like drinking excessively.
Yes. Okay. Well, the reason you came to this service was because you thought you should at least ameliorate it a little bit. Yes. But I think we do. We'll come back to that as well because there are dangerous assumptions within that. So, look, if you get a group of people whose lives you're trying to affect in a room, even just wearing a kind of role play hat, look at how many different outcomes suddenly you have got to handle or think about, because there's lots of stuff out there, and you're immediately into, that's a bit hard. I tell you what, we'll just listen to the commissioner. That's a bit complex, isn't it? Sorting all that information out. We'll just go back and do the easier thing. But you've got,
I think it's a really good point is that the positive implications of going to the pub for social reasons. Saying that as a founder of one of the country's first social enterprise pubs that gives 75% back to local charities.
responsible drinking.
So we're a local pub that gives 75% of all profits back to local food charities, different charities.
Okay, yeah.
So for us,
Yeah.
social drinking is really
It's
important.
perfectly, yeah. So it's
Also
about managing
charities
that.
we fund as well.
You've got to remember, just we're a group of people who think they've gone too far from that, and they've come in because they want to do something about it. And so there's all sorts of changes that the different people want to see, all of which are potentially outcomes. And that starts to get a little bit messy. But if you're interested in really creating value for people, you need to know whether you are delivering the things that they want. And one of the problems I see with a lot of the kind of this agenda is that we still have people who decide how to measure changes in other people's lives, which is always a bit extraordinary, I think, as opposed to those people telling us how they want those changes to be. But it does get a bit messy. What's missing from that? Before we get into any of these questions about causality or measurement, what's up there at the moment? There's something really big missing.
How are you going to measure if they have reduced their appetite?
Not yet. We'll get onto the measurement. There's a bigger thing missing first.
Only some people have.
Some people, clues in the word there. So some people reduce their drinking, which means that some people don't. And how do you think they feel? Demoralised. Yeah. So you said, I will help people, and you didn't for everybody, who are now worse off than they were before they came.
you might refer them to a more complex service.
We might. Okay, before we refer them anywhere, do you feel that you should be accountable in terms of measuring social value for those changes in those people who do not reduce their drinking?
I think you should, because as part of an integrated approach,
Yeah.
you should be providing some form of
Support.
coaching
Or whatever.
to
Yes, I agree.
enable them to change.
Agree.
Look at a
I absolutely agree, but does anybody think not? Because you do get, I mean, would you, Commissioner's point of view, you're going to be worrying about the people who don't reduce and don't become healthier?
Yes, because at the end of the day, I'm accountable for health outcomes across the
Great.
whole of Salford.
So in our contract, if we have this number smaller, we'll get more money. What about you, Chris?
If it's an outcomes-based
It could be.
contract,
It could be. Yeah, you might find that the commissioner is actually going to value that fact that not everyone will, and potentially they're worse. Chris, would you do anything about this lot?
We have to look them in the eye.
Yeah.
So they, in some senses, they will come back to haunt us if we can't
you
do
don't.
something more fundamental.
Richard?
So when it's commissioned, is there a hurdle above which it's successful and below
Let's have a
which...
look. We'll go and have a look. We'll come back to that. Yeah. Yeah. When we get the measurement. I'm just dealing with this kind of. A lot of the time, we see people who've got a purpose, an objective to do something good, and that's all they'll measure. They won't measure what happens to the people who don't get that. There's a kind of assumption that at least they'll be no worse off. Yeah. But I think in this situation, there's a quite a high risk that they will be worse off.
I think we'll be interested to see upfront sort of what is a reasonable amount, and this is a discussion and dialogue between the Commissioner and the contractor.
Some kind of target around that. Well, let's come on a bit. So we've got some people who don't, who are now depressed, and other things. Yeah, they're now more isolated, more lonely, more of those challenges that Chris was mentioning. Let's just imagine then, just for a second, that as we see that happening in this service, and you, Chris, you notice that this half are the people here who are getting healthier, fantastic, and you lot, unfortunately, aren't and are now much more depressed. What we notice is that you lot have quite strong family support. Seems you've got good networks and support around you, whereas you lot are much more that group that are isolated. And so we start to think back about the causes of this by seeing what kind of characteristics emerge. And you lot are all much more isolated. So what would you do, Chris, with that, now you see that happening?
My initial response, which is about how do I get you out of your homes? Because we know that the main cause, certainly in Salford, for the most problematic drinking now is going down the supermarket, buying cans, taking them home and drinking on your own. It's the not drinking socially problem. So the housing people tell us their biggest problem is getting single men out of flats.
So there they are. This is a mix of people who are single and drinking at home. What are you going to do?
Tempt them out through things like computer gaming.
Okay, so we're going to start dreaming up some other activities on top of our other one. I just want to make this, I don't know if this is realistic or not, but let's just assume it is. The Commissioner's not going to pay you to do that, and you haven't got any other money. The Commissioner's saying, I want you to focus on this bit, and I don't want you to start spending the money I've given you in your specification to start tempting people out with computer games courses. So just imagine that you can't get the money to tweak around the edges for a second. Do you have a view as to what you might like to see happen? You have this at the moment. Sorry, focusing on this group of our stakeholders here.
Try and use some of them as volunteers to help some of these.
Great. I mean, that's the next one. So we're going to get these people over, and they're going to come over and say, "Hi, I've got really good family support. You haven't." But just imagine. Obviously, but there is a difficulty in doing that. For that, I mean, you know, it's kind of that's how it does. It's danger of seeing. Yeah.
Yeah, there could be workshops, a mentor, somebody who's been through the whole process themselves,
Right.
some
Okay.
way of doing it,
Yes.
you know, more face-to-face approach.
So the tendency is, when you're worrying, is that, as Chris does, we should do something about this, to try and set up some kind of something ourselves. But what else could we do if we recognise our skills are in helping people do something else and not that? What else could we do? And someone's mentioned this idea.
You could let those people know your findings, and ask them, what, you know, this is what we found out.
Yeah.
How do you think we could?
Will you respond to that?
yeah, I think, personally,
Yeah.
as a good commissioner, I should be having a conversation with Chris about
Yeah.
this.
So there's a cycle.
Finding out why.
Yeah. So maybe about a year's time, when the contract comes up again, we might be able to do something about it. What about today, with a group of people knocking at the door?
Work in partnership
Who? Yeah. Who with?
with somebody who has a gaming company.
again, some kind of service, whether it could be some kind of other family support or whatever it is over there, which I'm going to make you, Richard, so you're now part of this team, okay, the support team. You've now solved your drinking problem, well done. And you're now running a family support service or games thinking, whatever it is. And we're going to signpost this group of people to that activity. Yeah?
Basically referral, isn't it?
A referral, whoever mentioned the referral. Are we accountable when we do that? Are you accountable for what happens to that group of people when you signpost them to Richard's outfit?
Not legally, no.
No, but do you feel you should nonetheless maintain some accountability for what's happening?
Yeah, if we built up a relationship with people.
Yeah. So you're starting to change the whole scope of what you're measuring now quite quickly, because now we've got to come into some kind of partnership arrangement. We've got to really understand what we do together. It's all got a bit more complicated again. Are you supporting the kind of joint commissioning approach that we're trying this? Certainly have, that'd be great. So we can go back, have a chat. Let's actually submit a joint tender next year. We're going to do something together, okay? This is looking good. But this is all about the culture now, and not actually at the moment anything to do with how we measure any of these things.
But you're still looking at it on a person-by-person basis. I mean, what about the net effect? So in that group, you're going to have some people who, if I reduce from 3 to 2, is that really?
Yes. Does that make any difference? Can we come back to that? You know, still on these difference between these two groups. I just want to have one more situation. You can't get any money for it, and there is nobody that you feel comfortable referring people to. What would you do then?
Set up a social enterprise pub.
You've got people knocking at the door today, Chris. You've got to decide what you're going to do with those people.
I think part of what we would look to do is to find out what are the strengths of these people, and can we create a different type of solution based on what they're interested in.
And in the meantime, while you're researching that, people are knocking at the door coming in who don't have good family support. Anybody else? What do you think you might do in that situation?
Well, you could, with those people.
I can see where you're going, but no.
You
There's one other thing, I think, which none of us want to do. I also sit on the board of a social enterprise called FRC in Liverpool, where we don't do what I'm going to suggest, but we drift a bit towards it because of the issues around.
I think you need to go back to the commission and say this is not working.
We do that, but today I've got people coming at the door. Sorry? Nothing.
Support group.
Nothing. Nothing.
Volunteer organisation.
Nothing. Go on, explore that.
Well, just because, you know, for all the reasons I'm saying, you're not getting paid for it, you have no responsibility for it, you have, you know, other than your social conscience.
Yeah. So would you still bring them in to your project, however, when you say nothing?
Well, I think you probably your social. It depends on, you know, it's like you're saying. It's like how far do you go? Because
Right.
actually,
I'm worried about that, but
You be honest with the person and say, look, this is what we could do. This may not work for you, but you
right. So I think, there's a bit of me which says you should not let them in your project, that group of people, at all. You have evidence that suggests if they do come, they will be more depressed. But because we don't want to do that, so we'll find a way. So you should say no. In practice, I think that's what certainly we do when I'm wearing that different hat on a social enterprise, is we'll tell you. I still worry about that because people will say, you will probably say as a group, thank you for that information, but that won't happen to me. I'll be different. Despite the evidence that suggests that is a characteristic of not being isolated, you're more likely to be stuck in that. So I just want to throw up the point that as we think about going to causes and we think about recognising that it's not just one group of people anymore, there's lots of very different types of people, there will be some you can't support, who actually could be worse if you did. So from the ethical point of view, I'd be very nervous about even letting them in, because we have evidence that says they're more depressed. But people tend to get nervous about that idea.
Couldn't you, when you go through the selection process, ask them if the project doesn't work for you, what will you consider as a solution?
You could.
Before they go through
Before
the
they start.
process.
Yeah.
Because then what you're doing
Yeah.
is if you let them go through the process and then they walk away,
Yeah.
one, your credibility as an organisation because word of
They've
mouth.
got worse, yes.
Yeah.
Yeah.
Two, that person becomes depressed, they could even go and abuse other substances,
Exactly. Okay.
become more
I
isolated.
agree. It could be, exactly. So you have a responsibility to do something, but if you can't bring them in and you can't refer them, so you ask them, and they go, this is what? And you go, well, we haven't got anybody to help that, I'm sorry, bye-bye. You already, the very entering into that conversation creates a set of, I think, ethical issues that you're not legally accountable for. And are not easy to fix, none of these, if you don't have a right answer for you, should you refer, should you set up a support group, should you do that, should you send people away, any of those, but you need a culture in a business or an organisation which is having that conversation when it recognises that's happening. We still haven't measured anything, so let's just move on, yeah, 'cause okay, so let's measure it. How, though, would we measure? We've got numbers of people there. That's great. We know roughly half and half. Half and half. But that's not telling us the point that somebody raised here, I think, about how much. So how would you measure healthier?
Impact?
We're gonna, well, that's not helping you measure healthier. It's,
How often they've had a drink, you can at the end of the programme or project, questionnaire, survey, informal kind of survey, face-to-face consultation with them to find out if
okay.
thinking has improved,
Yeah.
and then break it down into demographics.
Okay, so we can measure changing in drinking by all those characteristics. How do we feel about that as measuring healthier? Anne, from a commission point of view?
From a commission point of view,
I'm going back up here and I'm measuring this now. I'm not measuring that actually, I'm measuring that as an indicator of that.
Right, okay, because I was thinking about healthier, so in my head
Yes.
was in
Yeah, how would we know if people are healthy?
like blood pressure and
Right.
stuff like that. So clinical things
Yeah.
that you could measure.
Can you get that information? Can you get blood pressure out of everybody and go and provide that? Yes. Yeah? Fantastic. So how would you measure health apart from the blood pressure?
We would probably try and find a tool that reflects what's important to these people that also satisfies whoever's got the cash.
Yeah. It's good though. That's a juggling act, you know. But you need to find somewhere measuring health, which will have some potentially some of those kind of clinical issues. What else could you do to measure health? I'm sticking on the measure health bit.
Could it be other outcomes such as tendency sustainment, issues around antisocial behaviour?
Okay, so what is measuring social behaviour measuring?
It's measuring
A change in social behaviour. So
Yeah.
you could argue that as a result of becoming healthier, my social behaviour's changed. So this is the other problem with this, is that it doesn't stop at healthier. We're talking about people's lives over time. Actually, that goes on until people are dead, effectively, at an individual level. Yes.
I was going to say one thing that we're finding is becoming more and more important is measuring mental health. So there are some tools like WebWebs and things like that. So there's some, there's some standard ways of doing it.
That,
so
yeah.
we're sort of trying to work with providers like Chris so that
Yeah.
they're using it as well.
So we can, well, the depressed bit, if you want, is your mental health issue. And we're assuming here the healthier bit is your physical health issue, and the merging in there is a difference. But I do think the point that the outcome goes further than healthier is often lost. All this idea that it's some kind of moment, we fixed it, a final outcome. Well, hey, how on earth do we know what the final outcome is? Because you could, as you suggest, quite happily go further than that. So I'm not happy with people being healthier. It's not good enough. It still doesn't answer so what. Health is not that, physical health improvements are not necessarily very sustainable. And last, there's a risk that after a few months of that, you give up whatever it was that you were doing to keep healthier. Even if you don't go back to drinking, you just become less healthy again.
But doesn't this point show the need for greater partnership working with GPs? Because the GPs could provide that information in terms of, I've seen this client, oh, there's a change in that client, so you could measure their emotional well-being, their physical well-being.
Yeah, Chris?
So that's where that sort of data and real working
Can come in. Yeah.
comes in. And so, I mean, I've worked in local authority and commissioning, and my background's in nursing and social work, and I could see the importance of working with GPs. I mean, we know GPs are overstretched, but what about contracting with GPs or commissioning with GPs to give you some
Information
of that
about
data?
health, yeah. So we can do that.
For those who are registered with a GP, for those who go to a GP, but not for those who aren't.
Okay, but then one of the incentives to enable people to register is facilitating that, because I've worked with homeless people.
Okay, so there's quite a lot we could tease out in that, particularly if we had a lot longer to tease it out, but there's bits in there. But I still just want to hone this down for this. The issue that was raised about health still doesn't answer this. So what question? How many people here would be happy if we said, that's what the outcome for this group is that we're going to manage, the healthier bit? Or so how many say, yes, that's fine, that's good enough? 1, 2, 3. How many people says, no, I want to go further. I want to go further than the healthier. Wow. So quite a lot. So even in here, there's a decision to be made for which there is no nice, easy rule, which will, say that's not far enough or it is far enough.
I know I'm repeating myself, but you're never going to answer the so what question if you haven't found out what the actual cause is.
Of course. But you're still going to have to know. The causes people are going to refer to by people saying, actually what I want to know this is to address my housing issue because that was the root cause, or to address my isolation because that was the root cause. So by listening to what you all said, you stand a better chance of understanding what, from their perspective, is that root cause. And then you start to see you've got not just one group of people, but more than one. And in this simple example, we've just got 2, but in practice you could end up with more because you have different causes. Yeah. And do you want to add anything from a commissioning perspective at that point about how much further, because you wanted to go further?
I want to go further.
So where do you want to go to?
Recovery.
What does recovery look like?
Well, I mean, some of the things they were talking about, unemployment maybe, so sustainable, good employment maybe for some of them. It's going to vary person by person.
Yes.
It depends on what their aspirations are.
Yes, it's back to aspirations and causes.
Individual aspirations, isn't it?
So I think really you've got to accept that what's going to inform how far you go is going to be heavily influenced by what people think is the issue they need to be addressing, although they might not always be right.
I think there's 2 dangers though in that. One is looking at one problem in isolation. As a commissioner, you're looking at lots of different things. And there is a danger that the public then think, well, why that one particular group? Why so much money being spent on them in comparison with schools, health centres, etc., etc.? And I think where it's difficult to look at something like this is you haven't actually mentioned the amount of money available. And that will shape the service right from the start.
Agree. Which?
I think there's a fundamental difficulty with this, that if this is an alcohol service, that's all it's trying to address.
But that's not what was just said.
Yes, what commissioners have a problem in doing often is saying, here's an alcohol problem, therefore we'll commission an alcohol service. And it won't actually address
the systemic
issues like resilience, feelings of control,
No.
which are actually fundamental to changing people's behaviour.
Yeah. So thinking about what we measure by reference to the group of people whose lives are changing will push you into more of a system partnership solution, which won't be fixed that minute if the commissioner is one of those commissioners who's in that situation. But you do need to start this kind of lobbying process or the conversation that Anne's certainly up to have with you about how we can start to influence that in future. But these are not, these are not a quick fix around this. When we're thinking about those kind of systemic issues. You had a waving, Natalie.
If we measure well-being, then obviously it's encompassing all of those different aspects of a person's life, and it's measurable across commissioning.
Yeah. So I think just the well-being bit, because often we get that, should measure well-being. If I'm in this situation and I drink less, my well-being will probably go up. If I become healthier, it will change as well. If I go and deal with my other social issues, it will change. I would argue that all these things are aspects of well-being, and there's a danger of jumping to the big bucket called well-being, because again, you're not defining at the level of what people are saying is the cause they're trying to address, the change in a way that you can then make management decisions about improving and hopefully commissioning ones.
Can I just make a point maybe that, so I'm not from a public health background, I'm actually a landscape architect. Ended up in, how did that happen? Long story.
No, not now,
anyway,
later, yeah.
So I have no clinical knowledge or expertise or anything, but I now work in the public health team. But one thing I can see is in order for the money to be given out, we need to start putting it in boxes. In order to measure it, we need to understand it in this way. And it isn't right, and it's very difficult because there'll always be, oh, but what about this? So somebody like my team will be looking at alcohol, it will be and Chris will probably back me up. For a number of years, it's been looking individually at alcohol or drugs or, I don't know, smoking or something like that. And what's gradually happening is it's becoming more, well, how can you bring that together? Because no one person only drinks, very unlikely. They might also smoke, they might also take drugs, they might also be overweight, etc., etc. In fact, we know from the statistics on the population that they probably are, and they're probably a certain age, and they're probably a certain demographic. So, but in order to do all of this, we've got to understand it, we've got to unpack it. So really, we've got to unpack it to give the money out, but it's got to be a discussion to unpack it, to measure it.
So that's all quite messy, but what we have to start worrying about, yeah?
I'm in public health procurement at Surrey County Council. I can certainly reflect those comments. Exactly the same in our area, and what we're seeing more of is incentivised areas of contracts whereby, so an example that springs immediately to mind, we've got a complex drug and alcohol inpatient facility where we're treating a number of people. They will run as part of the scope of that contract, a stop smoking service, which will require them to link in with our stop smoking contract.
Yeah.
So there is more and more of that going on. How you measure that across different contracts, and especially in payment by results contracts, then figure out who gets paid what for
It's
who.
difficult.
It's really difficult.
So when you're selling something through to a commissioners, I hope what we recognise from this is that a lot of commissioning is seriously trying to address these issues, and it is not simple to work out where to be in that case. And if you have the culture that Chris and his organisation have to try and think this way and think about where the root causes are, you stand a better chance of having a relationship. But this is still in this kind of system issues about relationships between providers and commissioners, and the relationships between how you think about what your responsibility is and how accountable you should be and all these things, rather than getting really hung up on a set of measures. So on this lot, I think we had some very simple measures. We had something about body weight and people being more depressed using a Rosenberg scale. I mean, Anne mentioned one of the scales. There are a few scales out there with lots and lots of research behind them. Actually, I think the challenge these days is there are so many ways of measuring each thing. It's which is the one that I should use, rather than it is, oh, it's too difficult to measure. I mean, a few years ago it was, oh, I don't know how to measure that. Now I think it's so many measurement techniques. Finding the one that, as you said, is appropriate for two different audiences. And do you find that's always possible, or do you find that sometimes you just can't square that circle?
It can be difficult. I mean, the ones I prefer to go for are ones that are actually relevant, that we can use as a tool with an individual, that they measure themselves against a validated tool. So we can actually use it as a tool rather than just as a measurement.
Example?
You can use something like the outcome star.
Yeah, everybody heard of that? Yeah. So for outcome star. So it's got predefined kind of scales around a star of effectively changes in people's lives that they can recognise in themselves and see and kind of self-score against. So if you've got a stakeholder group that is on that star and an issue that group of people want to see change in their lives, and there's a star for it, it can be a very useful way of measuring things. Do you use that in any commissioning?
We do, yes. I mean, I know, so colleagues in the Children's Services actually have designed a performance framework for contracts around the questions and the outcomes, the relevant outcome stars. So, you know, it links the two together. So the questions being asked gives the evidence back that the commissions are actually asking for.
Right.
But that's come out of a dialogue with providers.
Okay, well, let's crack on. Someone asked a question about, is there a a limit earlier about, you know, how many people. So can you just jot down, don't really want to do it, just kind of, or at least say in your head and then stick to it, whatever you say. You're running this service now, pretend, and you've got 50 people coming through, and you can't help everybody, so there will potentially be some people down here. But what is the threshold for you, at which point you would go, that's too many, I must change my service now? So how many would you be willing to say, I can't help everybody, it's going to happen, I don't really know why that's happened, but I'm going to have, is it, how many? So in your heads, or jot it down. Because I found if you ask people this individually, the person who says it first, everyone tracks that number. It's kind of psychological drag. Whereas if you do it honestly and write it down, you get a much bigger range of answers. So, everyone done that in their head? Roughly? Yeah? So, Chris, what's your minimum? Before you say, I must change things. Or the maximum, rather.
Maximum number of people.
Who becoming depressed as a result of this?
10.
10 out of 50.
Who failed?
Who down here? Yeah. 10. Right, anybody else? Anybody below that?
10% of
5. Well, hey. Anybody above that?
15.
15? 20? 6 out of 50. So you'd be happy to have just over half becoming depressed, so long as you had just under half becoming healthier, or wherever we decided to rest our decision about how far we should go. Wow. Then you have to reflect on the number of depressed people you now have in the... Why 60%?
Well, I think, you are impacting
You're still creating some positive,
it's
positive
quite
value.
a hard area to tackle, so you're making a
Okay.
impact.
Anybody else?
Isn't there an economic scale here? What's adding cost? What the cost? I mean, I'm a private business owner, so
Yeah.
I'd be worrying about the cost of providing this service and how that's coming back as in less cost to the community at the end of it.
So remember, we've got another version of this, which is the stakeholder who is effectively the kind of society represented potentially by the health service or whatever it is, where they will have some values relating to these, which are your costs, if you want. But at the moment, we're just dealing with from the perspective of those you as people, not from the economic cost to another group of people, of which we are members as taxpayers.
But to get to the amount of people that you are happy not to serve through this process is going to be determined.
Okay, maybe. So what else? So, because everyone in the room has come to a view about what that relationship is without reference to that particular source of value, which is one source of value. But we've all done it. Everyone has made a value judgment about 5 at the low end. No one was below 5. Up to what, 60% of 50? Thank you. I'm an accountant, for God's sake. Or was. So, between 5 and 30, there's a massive range there. And everybody has got a view on that. And what's interesting is that most of the time, organisations don't have that discussion. Because a lot of the time, they're not even seeing this group, remember? They're focusing on the positive, intended things they want to do. And a lot of the conversation we've been having about the second group of people doesn't really emerge. How do you have that conversation about 10 in the organisation? Or is that yours, the 10?
Somebody has to come to a judgment about it.
Yeah. And what's the process by which that...
The easy way is I decide.
Yeah, the truth is.
There'll be a cost benefit.
Somewhere in there, to your point, but yeah.
I think using some kind of timetable or a forecast, some kind of strategic plan can enable you to know what your limits are.
Right.
And rather than just letting everyone in to use the service, you need to be able to monitor the costs of running the service and also to predict the future.
So I think it's very important, that point, that you should have a plan for this. I mean, it needs to be addressed up front, and so often isn't. We say, okay, what is the plan? The plan is 10, we'll say, not 30 or not 5, we're going to go with 10. But how do we get to that if we're not going to just rely on Chris to decide? And to be honest, I'm nervous about just using the external economic cost bits to society as a way of making that judgment. So how else could we decide? Any views?
We're going to consult a bravely banded people. I've just discovered exist called health economists who are going to tell us what the benchmark is.
So they're there. So that's still by reference. Well, it depends on your health economists really, but what techniques would they be using to just make that judgment? I mean, you've got some of them are what are the costs to society, the taxpayer? How much is it going to cost the taxpayer if we have that group there? And how much are we going to save to the taxpayer if we have that group there? But is that the way we should measure that, or is there some other view about how we should do that? We've got Chris or that.
You'd look at previous contracts and see how successful they were and try and up it a bit.
Okay, so everybody else used to do 12, but we're on 10, so that's great. Yeah, that's good, but there's still an issue, I think. Yeah.
Chris needs to look at his capacity internally, because it might be that they're taking on too many people. They don't have the resource to deal with all those people.
So maybe he should send them away, some people, and then you won't have 10 anymore. You only have 5 because you've not even let them in the door. Okay, so we're down to 45 in the room. Yeah. I'm still in something else.
I think you have to think about it in time. So perhaps you start off with a bigger amount that you will allow to fail. That has been doing properly.
Yeah.
And maybe it's about the difference you've made to both groups, rather than just the number that went each way.
Yeah.
And then about how long that lasts for. Is it a temporary depression that may pass?
So there's going to be a duration question in
Whereas
there.
the ones that succeed may have a significant longer term or not.
So we've thrown some challenges in here. We've already got the causation, which we haven't addressed yet. We've got the duration problem in here. But I still think that actually you have a say in the relative importance of these things. Not the tactics, go on.
Wouldn't the numbers be in the initial commissioning tendering document, how many people do you expect it to work anyway?
But that might say that. Your threshold is 10, in which case it's not Chris making the decision, it's the commission making the decision.
Numbers attached to it would be impossible anyway.
Correct. So at some point, but even if you have a commission who doesn't, Chris should still be worrying about it because lives are being made worse. And what is an acceptable level of worseness is often not a commissioner's question, it's should I be worrying about that? Because remember, you don't have any power in this conversation. You can't turn up at his AGM, you can't go to another service so easily. You don't have, he's acting a bit on your behalf. Hold that thought, yeah.
He needs to be considering his approach. And I think there's a danger, it sounds like it's a one-size-fits-all approach. And I think evidence shows where you try that, you get more casualties. And actually, if you've got more adaptability and flexibility,
It might go 10, 9, 8,
user
12.
involvement,
Yeah.
then your success rate.
But I still want to press you at the user involvement in this conversation about how we decide what is a minimum. What is the relative importance of these two different things? Not by reference to an economic cost model, not by reference to Chris sitting there in a dark room going, it's 10. How else could you do it?
But surely before you actually have the service being commissioned, there's some part before where you consult with the users so that when the service is created, it's targeted to minimize the people who drop out. And those people are very, they're aware of that, they accept that. There'll be some people that
It won't,
help.
but we can start that service and we'll get some results and we can get better. But the question is still at a strategic level, what is it 10 or 5? And I see there's absolutely nothing wrong with going back to you as a group of people and asking the same question. What is the relative importance of one of those compared to the other of those? And ask users how important those two outcomes are relative to each other and weight them. It's very difficult to make design solutions without some understanding of how important one thing is compared to another. And there's a lot more going on now around how you can not only rank those just by simply asking people, what's the ranking of those two things, which can be just as good as some of the more expensive well-being valuation techniques, which actually put a monetary value not on costs, but on my change in my well-being because I am more depressed. And what you tend to find is something like that people value their mental health considerably more than their physical health. Considerably more. So if you ask people and look at the research on that, you get a ranking which basically says with 50 people, 12.5 is a break-even point. That's the point at which you're not destroying any value. You're not creating any value either. It's a zero-sum game. You've spent some money to say, well, what about the cost of all this? And what you've achieved is zero, net. And if we go, well, that doesn't feel right, but that's what's happening. Some people's lives have improved, but the value to them of that improvement for physical health is less than the value you destroy for people who have lost their, or losing a share of some of their mental health. And that, therefore, is a strategic conversation which we often don't have, or the CEO has, or the commissioner, which we need to have, I think, increasingly when we decide what we should be managing here rather than measuring all the time, is what is an appropriate level by reference to you, not by reference to any other source. But we haven't got more time for that, we're going to keep going. Because we have the causality problem. Was it actually caused by us? So how would we know that the people who are healthier was caused by us? Anybody?
We'd ask them.
Ask them. Anything wrong with that? Lots? Go on, why?
Yeah, I think you have to have, encompassing that is you have to have some sort of, I'll use the word robust, but you need to have some sort of robust evaluation.
Okay, so, commissioners, how would you assess the risk of, if we're going to go further as you want to, you're increasing the chance that the cause is something else, so how would you manage that risk in your commissioning?
Do you know what? I don't know.
Chris, do you care about the fact that, that it might have happened anyway? Some of those people would have become healthier independent of your activity.
Commercially, no.
No?
Socially, yes,
Why?
because that's our
Ethos.
stated mission.
Yeah, okay.
Can I, well, okay, so I've had another little think about this.
Yeah.
But part of the issue, I guess, is from the way that a service like this would be commissioned, is that people in Ireland, I hope the lady from public health over there doesn't disagree, but we sort of focus on the health of the population in the area at a level up here.
Yeah.
And we're looking at those and we're thinking, oh yes, the mortality rates and the X, Y, Z, and that's all improving and that's great. We must be doing the right thing in Salford. But we don't always necessarily track well enough to make the cause and effect.
Yeah, but you should be doing that, shouldn't you?
Well, we like it.
Yeah,
So
okay.
who's responsible then?
Yeah, that's good question, Roger. Sorry. Yeah.
So, it seems to me that really you just can't do this on a local level, and that actually, with all of these commissioning decisions, when money's tight, we need to get beyond the kind of outcome measure world, and we need to be looking at the fidelity of implementation of proven programs. And then you don't have to do it locally. Right. An RCT done somewhere.
So to who's responsible, can we go to look at some randomised controlled trial methodology that wasn't done in our area, it was done somewhere else, and maybe we can use that. Anybody? Any thoughts on that? I think there's a point in there, we have to do that, yeah? You had a, yeah? You put your hand up? No? No, you just wave your pen, okay.
I have a little think about that. I think there's different elements to it. Partly is a lot of the commission decisions are driven by national requirements. There's national reporting
So there's some
requirements.
research done, yeah?
Minimum standards that is based on research.
Yeah.
But on the other end of the spectrum, we in Surrey know where our problem areas are, and we ask our providers to chuck resource in certain deprived areas. So it's a delicate balance to take between national and local.
Should the delivery of the service take that into account? Because if there's some people who would have got better anyway, maybe they look at the resources and time they put into those people would maybe wait.
So here's a key bit. If you can identify the people for whom it would have got better anyway, it's a commercial issue, surely, because you can allocate resources in a more targeted way. So at the one end, at the strategy level, this causation thing does have an RCT type research over there happening. But I really think asking people at an operational level can be really helpful. I mean, we've had this conversation, again, swapping hats briefly to be on the board of a social enterprise. Half the board go, well, why do we want to know that? We got them into jobs, that's fine. And the other half are going, but if we knew why, we could have spent the money more effectively. Wouldn't that be good? So that debate goes. And the asking people is a way of identifying, potentially, that you lot don't have great support, and you lot do. And that allows us to understand some sense of the causality, because those who don't have good family support are ending up down here. So it's a perfectly good question for teasing out differences. Yeah. Without the RCT, yeah.
I don't think you can just say without the RCT, because what's happening is Surrey's doing...
No, I'm not saying without. I'm saying they're two different things.
Well,
but you do both.
No, I think what happens is if you do this with a small number of people in a local area, it can send you off in entirely the wrong direction. And the danger is that actually you can be going in the opposite direction to well-proven RCT interventions, because for whatever reason you've asked your local services and your 25 people or 50 people are the outliers, are going somewhere else.
So this is all possibly true. You could, but equally, if you don't ask the question at the local level, I'd argue, you risk taking an average from an RCT, which is not the people whose lives you're working with. There's no right answer.
Hang on. You're getting away from... I mean, if health is anything, it's an evidence-based intervention. You know, cancer treatment, everything else in health, stop smoking programs are all based on very large samples saying, this is what happens when you apply this across the board.
Yes.
If you go to a local area and say, otherwise what you end up with is someone saying, my uncle smoked till he was 90 and he was perfectly healthy.
We've got 3 minutes, so take your point. Chris answer? Yeah.
The evidence question is really interesting. So if you take something like stop smoking, the evidence is that most people never go near a stop smoking service, and most people who quit actually get no support whatsoever.
Absolutely.
In which case the answer is have no services.
No, that's not
okay. We're going to take this conversation outside.
Give up without going near a service.
I think
don't have any services. it means that you're dealing with apples and pears.
We haven't got time for all of it. My point for you is that these debates don't have necessarily a right answer, and people feel strongly about them. And at a board level, sitting on a conversation, this is a conversation that should be being had. This conversation should be being had, in order that you stand a better chance of making decisions that will increase the value that you're creating for people. If that's debate, which is a healthy debate, but we just don't have time for it now, because what you're trying to do is say, this argument, will it help us make a decision that will design a service that will create more value for you? And if we just dump all the national research and design a service, there's a risk to that. Equally, if we don't understand what's important to you, there's a risk to that. And we have to worry about both of those things. Those of us sitting on some of those, when you have to make those decisions. But we'll park that bit, it's interesting. So, just want to give you an extreme case in this situation then with this project where everybody with family support would have got healthier anyway. And everybody without family support is the ones who are getting depressed. What would you do now if you come up with that result?
Well, you work with that.
Right, so what's wrong with the project? So this question about people have been raising, should, you know, the silos of a project which is dealing with reducing drinking is a rubbish project, frankly. It's not addressing the cause, you should dump it. There's a real danger of organisations fixating their objectives, because these difficult questions sometimes cause you to think, really, do you know what? It's the wrong thing we're doing, and we need to, that's an extreme case. But that open culture of trying to think through together about, actually, we need to actually do something quite different and stop trying to reduce drinking, because in this case we should be trying to support people. For your early point, that thinking process that so many organisations get stuck in, if they're not going back to the causes, which in your case, you're never going to change anything. And you might have organisations which are spending money, potentially doing this, or even doing that, and meeting a commissioner's requirements, but actually in this scenario are destroying value, wasting money, and the only outcome they have is a bunch of depressed people. But you can hide from that if you're not thinking about measuring the right things as opposed to how to measure the things that you're measuring in the first place. So just to whiz through then, if you're going to worry about what we're going to measure, you need some understanding of the relationship between what you spend and what happens. We need to know who the different groups are and how they change. You need to really drill down into that to the level that you can in order to understand what different people are driven by and what the causes are underlying that. You should also use third-party research, whatever that might be, to support that research. There's a thing about this, how far do you go, which you cannot escape if you move away from just, you know, kind of measuring objectives. You can't just kind of jump in. How far? When is it sustainable? If people have got a kind of addictive tendency and they stop drinking, there's a risk that they take over some other form of addictive behaviour. It's just not sustainable. You've got to, and there's not a fixed answer on that. Who should we therefore be working with? It's as much about collective partnership as anything else. And don't forget everybody that you're working with. There's such a tendency that we only think about measuring change for the one group of people working with and the other one. So we have some principles as an organisation which help you reflect on all those bits. We kind of believe very strongly that these have to be applied in different ways, in different situations. You're all in different situations. And a set of core principles really help you keep this, that Chris has in his heart, that sense of accountability for thinking about things. But organisations need things in place to ensure that that sticks. Keeping that embedded is tough. And this is an example of that lot then, popping out from software. So, Anne, do you want to reflect on that? Because that's some of the thinking that we've been talking about, emerging then into effectively a measurement framework.
Okay, so this is something that Chris has been involved in developing as well through their Health and Wellbeing Board in Salford, which is a group of organisations, including local authorities, including the NHS, including providing organisations, including social enterprises, voluntary community sector. And the most important thing really is that second column, is what difference is that making for the people of Salford. So we're sort of working under the devolution agreement in Greater Manchester, and we're looking at Salford and saying, right, okay, how can we make sure that everything we do and every bit of money we spend actually aligns back up to those outcomes? And there's outcomes around living well, there's some around starting well, which is sort of supporting young people, families, things like that, best start in life for people who've got a sort of public health, it's all the sort of marmot type stuff. And then there's an ageing well one, which is about older people's health, adult social care, things like that, but the same sort of thing, that actually actually trying to get this accountability through. And then the right-hand column is a dashboard that the Health and Wellbeing Board is using to sort of keep an eye on that. So just sort of using a set of indicators that are up there, but actually trying to get that accountability through, right through to the services and what is making a difference for the services. But it's in discussion. It's not something
Not fixed.
yeah. It's not
Chris, any kind of vaguely final thoughts?
The process that Anne's describing, I think the biggest change we've made in that second column, because the original statements didn't read like that. The original statements were very generic about population change, and what we went through was to get to a statement where those outcomes are stated as I, my, so as it becomes personalised. And in a sense, the Health and Wellbeing Board, in doing this, in one sense has gone through a sort of emotional process of getting back to thinking about an individual person, in the same way that the media puts across stories by focusing on one individual, because people can relate to it in there.
Okay, any reflections, any thoughts?
Just really just thinking about the relationship between the provider and the commissioner, is that you're making, again, more to add to the case that there needs to be equity in terms of that relationship, and obviously people in this room will know that, but the importance of working in this way, in partnership across a particular area, and that people are known as experts, that the organisations are recognised as experts and can inform commissioning as it goes forward about what works and what doesn't, and provide evidence of that, and how important that is in the whole commissioning process, and in terms of knowing what creating social value really means
for people's lives.
in a community.
Yeah. Yes.
Can I just make a final comment from me, really, which sort of builds from what Charlotte was saying, that one thing we've learned, maybe over the last few years, we started out doing stuff around social value, and Chris was involved, and voluntary community sector, lots of people involved in Salford. And we always thought social value was something to sort of add on to the end of this. And we've graduated, and then we had commissioners who worked on these sorts of measures, and we had providers who were talking about social value in terms of local employment, local supply chains, building skills, volunteering, all sorts of things like that. But what we've been trying to do is actually stop it being something you add on and build it into the contract by going through these sorts of thought processes.
Which takes us full circle. And my only request or kind of beg is that if you benchmark now what social value you're creating now, you will be able to see how much more you're creating by a process of embedding. But if you don't, you will still be stuck with, that's happening, isn't it great? But we don't know how much has increased, and so we will still be in the, let's have some added value because at least we can add those things on. We've come to a bit of an end. These are some stuff that we offer as services, but I wouldn't be doing the right thing if I didn't say join, if you're interested in this conversation, because these questions don't get resolved technical level, all of them. They need communities of people sharing, arguing, practicing, and seeing what emerges from that. And don't forget, though, if you don't measure it, you don't treasure it. Right. So that's us. Given you can harass me on email or Twitter, whatever you want. I hope that was useful. We can carry on the conversations, obviously, after lunch. We're doing this again after lunch. So if you do have any feedback about what we should do differently, please tell us, because otherwise we'll just be rolling it out in a very similar way. Thank you very much, everybody. Lunchtime is back through there, I guess.